The Forum at 8 with Xolani Gwala.
9 minutes after 8, good morning indeed, and a warm welcome to the Forum at 8 here on SAFM, South Africa's news and information leader. Well, the Minister of Health, Dr. Aaron Motsoaledi, delivering a keynote address at the 6th Annual Conference on Competition Law at Wits University. Among other things, he reiterated that it has become an undeniable fact that healthcare in this country is simply unaffordable to the majority of people. He said prices have escalated to uncontrollable levels and that it is not over-exaggeration to describe the situation as the law of the jungle, where the principle of survival of the fittest exists. On the forum then, we'll ask about the cost drivers. What is it that is behind this escalation of costs? But also what can be done then in order to bring them to reasonable levels and ensure that everybody has access to health care in this country. To talk to us about those matters then, we have on our lines the Minister of Health, Dr. Aaron Motsoaledi. Dr. Motsoaledi, good morning.
Good morning, Xolani, and good morning to the listener.
Thank you for your time. Here with me in studio, I have Mr. Mark Haywood. He is the Executive Director of Section 27. Mr. Haywood, good morning. Thanks indeed for your time. We'll certainly make sure that people can hear you loud and clear, yeah?
Yep.
Fantastic.
Okay.
Fantastic. In a little while, we're also expecting Dr. Humphrey Zogufa, who is the MD of the Board of Healthcare Funders, to come through, talk to us. I think he's on the line now. Dr. Zogufa, good morning.
Yes, I'm on the line, Xolani. Good morning.
Thank you. Thank you for your time, Dr. Zogufa. Thanks indeed.
Yes, sir.
Sure. Let me start with the Minister. Minister, please, if you can paint the scenario for us. Because what seems to have happened here, and from your speech, my understanding was that we're caught in a no man's land in a sense, because the public healthcare system in this country is crumbling. And you admitted it yourself there in the speech. On the other hand, the private healthcare is just really for the rich only in this country.
Yes, Xolani, that's true. If you look at the green paper on NHI, when we released it last year, I said there are two preconditions for NHI to survive. Remember, the World Organization described a system like NHI as universal coverage, which they encourage for every country. Mm-hmm. Universal meaning nobody must be left out, and I'm sure you'll agree with me on that.
Sure.
Now, I said for such a system to exist in the country, there are two preconditions. Firstly, that the public healthcare system must dramatically improve, and I said it must be completely overhauled. In other words, it must look completely different from what it is today. But I said the second precondition is that the prices in private healthcare needs to be regulated, because they are the ones which I'm describing as the law of the jungle, where it's survival of the fittest. Because they just shot up. They just shot up tremendously, to dizzying heights, as I've said, from 1998, and that's why I'm saying it's unaffordable. So yes, there are two problems in the country: the deteriorating quality in public health, where we are doing everything in our power to put laws and systems to try and improve it. Sure. But there's this ever-escalating cost. But the question, Xolani, which I was asking, why people keep on saying private health care is expensive because public health care is deteriorating quality. I can't find the link in that. I simply cannot find the link.
Is it not an issue of demand and supply?
No. You see, that's exactly what I'm against, because we are talking about health here. We dare not apply the rules of supply and demand in healthcare, because, as I said in the speech, it's not any other commodity. And the World Organization also described it as such. It's not any other commodity. And I think that's where lies the problem.
Okay, let's put aside the issue of demand and supply and talk about this 1998, because you date this back to 1998. What happened then?
What happened is that the private hospital groups did what is called the market concentration. By the way, this report is even contained in the research by the Human Rights Commission. So it's not only me, but also the Council of Medical Schemes. So many researchers discovered that the problem started in 1998 when there was market concentration. In market concentration, you get more power, you kill the smallest players, but you get more arrogant and you get more greedy. And you call the shots, you just call any price you want, even if it's not necessary, because nobody else can do anything. You are the boss in the crawl. And I think that is what happened in 1998.
Why did the market concentration only start in 1998? Is there a piece of legislation that allowed it? Or was it because the department perhaps took its foot off the pedal in terms of trying to ensure that everyone has access to pure medical care?
I don't think it had anything to do with any legislation. It was business imperative. And I'm saying that's where the problem lies, because I am saying whoever is involved in healthcare must get involved on the basis that health is not any other commodity. And that was not taken into consideration when they did this market concentration. You can do it in other fields, the issue of market concentration. And I think it's a business principle. But in health, because it's not any other commodity, once you do that, we'll be in this situation where we are today.
Let me bring in Mark Haywood. You've done a lot of work here as Section 27. Where did the problem begin and why?
Well, as you've said, it has been going on for more than a decade now. And what we've seen in the last decade is various attempts by the Department of Health to intervene and to regulate prices in the private healthcare sector, to set reference lists for prices. And these attempts have been shot down, and they've often been shot down because of a combination of error, if you like, by the Department of Health, but also because private hospitals are very, very profitable, and there are very strong vested interests in trying to maintain the status quo of an unregulated private healthcare sector. So, as we sit here in 2012, we're very little better off than we were in 1998 or 2002, which is why I think it is good to hear the intention now of the minister to take serious steps to start to try to regulate the prices of private healthcare. And, one of the things that the minister's speech contributed to on Friday was a decision by the Competition Commission to conduct an inquiry into trying to understand what is the actual drivers of prices, high prices, in the private healthcare sector. And I think that inquiry is very necessary, Xolani, because lots of people give different reasons as to why are the prices of specialists so high, why are the prices of pathologists so high, why is the prices of hospitals, and each one says it's not me, it's not me, it's not me, but the ordinary person in the street feels it in their pockets. So an independent, objective market inquiry would allow us to see where is the problem and then to much more effectively regulate the problem. Look, and if I can just make one other point, though, from what you said a little bit earlier on, is that, it's true, it's not true, in fact, that high prices of private healthcare only affect the rich and the middle class. Precisely because of the poor state of the public health system, many poorer people have no choice. If they want to get healthcare and they get very sick, they have to go to a private GP or to a private hospital. In this country, we pay more than 20 billion rand per annum in what's called out-of-pocket expenditure. So that's not what you pay for your medical aid scheme. It's what somebody takes out of their pocket when they are in need of health, and the only way they can access it is by going into the private healthcare sector. So, there is this relationship between the two, as you're pointing to, and we have to try to settle this relationship so that the private helps the public and the public helps the private, which is why Minister Motsoaledi is absolutely correct when he says there's two things we have to do. We have to sort out the public sector, which is in terrible crisis at the moment, and we have to improve both the quality and the affordability of the private health sector.
Let's talk about the role, though, of medical aid, for instance. What do those people? What is their responsibility in the inflation, in the escalation of the prices here, Dr. Zokufa?
Well, the medical aid schemes are very concerned about this trend of increasing healthcare costs. I mean, if you listen to the statements we've been making since 2005 to date, all point to that fact that we are concerned that the cost of healthcare in the private sector is increasing. And we have identified gaps in terms of why that is happening. And gaps speak to the fact that it is an unregulated environment. You have an uneven intervention here, where on the side of the medical aid schemes, which collects all the money from the members, that's highly regulated in terms of what you collect and how you use it. Whereas the supply side of it, when it comes to private hospitals, specialists, various surgical procedures, radiological, pathologicals, that's not regulated. An intervention in 2002, 2003 to regulate the medicines and pharmaceutical products led to a reduction of about 19% in terms of medicinal costs. But that was taken up by an increase in the other spheres of healthcare practice which were not regulated. So basically the way the market behaves is you regulate me here and then I'll just load that loss somewhere else where it is not regulated. So there has to be total regulation of the entire sector.
Okay.
And that
I'll throw this back to the minister, because the minister earlier on said it had nothing to do with regulation, and he will respond to that issue. But let me ask you again, Dr. Zogufa, to respond to this issue of Competition Commission. Now there's the suggestion that there must be an inquiry. But what was their responsibility in the first place? Because as I understand it, there was a ruling when 2003-2004 by the Competition Commission, where then the comparing of prices was forbidden.
Yes, unfortunately, the Competition Commission did not fully understand what was going on in the private sector, because they said what the medical schemes were doing, the private healthcare providers were doing at the time, is colluding and price fixing. Whereas the attempt was to fully understand what the constraints and problems are with healthcare providers, and then healthcare providers begin to understand the problems that are there in the funding environment. And then the two parties then see to what extent they can negotiate a tariff that can be borne by both parties. Now, with the abolition of that, with the Competition Commission saying that was colluding, that was anti-competitive, it led to a situation now where it was free for all. And we are saying that was a mistake. That decision has to be reversed. And even this inquiry that the minister is talking about, we support that. But what we would like to see is that commission of inquiry having enough teeth to try and validate whatever the various providers are bringing forward to that commission. Because we're in a situation where there's no transparency. The commission cannot just accept what is being forwarded to it and make a decision and assessment based on that. It must have teeth to be able to validate that by seizure, subpoenaing, and also forcing people to come up with the real truth.
All right. Minister, please respond.
Hello?
Yes, please, if you may respond to me, because to what is, for me, to what has already been raised here, because clearly there are regulatory issues as highlighted by Dr. Zogufa.
Oh, no, definitely. Xolani, I heard you saying, I said this, it's got nothing to do with regulation. Did you say so?
That's what I thought you heard. You said at the beginning that it wasn't much about regulation, but it was about the concentration that happened, the consolidation that happened.
No. I thought you said, was there a law in 1998
okay,
which was passed? And I said, no, it has got nothing to do with the law.
Okay.
It was market concentration. Yes, Dr. Zogufa is right. And even the report by the Human Rights Commission shows that regulation in health is happening only on one side. We regulate medical aid schemes all the time through the Council of Medical Aids. Very recently, you had the Consumer Protection Commission also trying to regulate medical schemes. What has never happened is that the providers are never regulated. And that's what Dr. Zogufa is talking about. He's perfectly right, that there must be regulation of prices. That's why I said, Xolani, there are two preconditions. The prices of medical care has to be regulated and be brought under control. The public health system has to work. So regulation is very important. Remember that in the private healthcare sector, PALM has made statements that we must leave it to market forces and not interfere. And you know, Xolani, market forces are never perfect. They brought the world to these problems where it is. And every time market forces fail, government is blamed. Yes.
But it's interesting then, because if you agree with what Dr. Zogufa is saying, then it means we know who the cost drivers are, because the cost drivers are not the regulated element, but the unregulated element.
Yes, no, we definitely do, but the problem is that those who are involved in there are fiercely contesting what you are saying. We know definitely. I mean, it's even recorded. We have got the graphs. If you look at the amount of money collected by medical aid schemes, you realize that, I mean, let me just give you the one I remember, the 2010 financial year. The amount of money collected was about 84.7 billion, and 30 billion went to private hospitals. That's number one. And then about 19 billion went to specialists. Those are the highest cost drivers in the healthcare system. Medicines used to be a problem until we regulated them and they came down. Some people believe, for instance, Xolani, that GPs, those who are in private practice, only surgeries who are specialists, are also expensive. Those are people who are the biggest losers together with patients. in the whole system, because out of 84 billion rand, they got only 16 billion. All of them, remember, just imagine how many GPs are there in South Africa, getting 6 billion out of 84 billion. Why? Because it's survival of the fittest. Those who are big and strong call the shots and take all the money and tell everybody else to go to hell. Because every time you talk to them, they say, look, the problem is not us, please go and fix the public healthcare system. We are here, we are providing good quality, we'll call any price we want. And that's exactly where the problem is.
Mark, let's come in then. Because presumably, if we know who the cost drivers are, we really have got to tackle that. Don't make it everyone else's problem. Just tackle the cost drivers once and for all, Mark Haywood.
Well, yes, we do need to tackle the cost drivers. And again, I agree with exactly what the Minister has said. I mean, there's some research done by the Competition Commission that shows that of all expenditure on private healthcare, 20% goes to specialists and a further 36% goes to private hospitals. So almost 60% is on those two groups. But you see, the problem is, Xolani, is that this area is contested. And they will say, no, it's not us, and they throw smoke and so on and so on. So what we really need to do is to get to the bottom of where precisely is the escalation coming from and how best can we regulate it. And the reason why I say this is necessary is because, as we said, for 10 years there have been stop, start, and the only people who suffer from the stop, start is the consumers, is the people who need healthcare. Meanwhile, the healthcare system continues to operate in this distorted fashion. So I think this inquiry gives us an opportunity. What I would agree with Dr. Zikufa is to say that the inquiry has to have teeth. Now, one of the problems we have at the moment with the inquiry, and I hope that perhaps Dr. Motsoaledi will lobby the president on this, is that the Competition Amendment Act created a special new power for market inquiries by the Competition Commission. But that Amendment Act has been sitting, waiting for signature by the president for more than 3 years. So unless that chapter is passed quickly, then the Commission will not have the powers that it needs to subpoena, to properly analyze the evidence, etc., etc. So
that's an interesting point, and I'm going to go back to Dr. Zikufa in a second, just to clarify exactly, if we say teeth, then what is it that we want, Dr. Zikufa?
Well, what we want, Xolani, is because there's smokes and mirrors, because there's no transparency, if you have a commission of inquiry there that begins to ask people to give them data, they will definitely give them the data that supports and entrenches what currently happens. And if that commission of inquiry doesn't have the means to validate that data by searching or seizing, then it will just endorse what is happening. So what's the point of having a commission of inquiry?
So we'll end up in the same situation that Minister describes in his speech on Friday, where people do research selectively just to prove their point, Minister.
Yes. That's why the Competition Commission must be the one that the market inquiry, which must be held in public. Because at the moment, everybody say, oh, they are blaming me. I've got money. I'm going to commission a research, look for a few scientists or researchers who will conduct the research and exonerate them and blame their perceived enemies. Then another research comes in. Like I said, Xolani, the most laughable one was that the prices are because of the elderly. Can you imagine? It's a research conducted by somebody who said, no, the problem here are the elderly. I mean, how does anybody conduct a research that comes to that conclusion? That prices are high because people are old.
Right, we'll open the lines here for people to also air their views on this one. It's an important matter that affects everyone across the board. 0891 104 208, 0891 104 208. But I suppose, Minister, one of the biggest questions that you're going to have to deal with is the one that comes through from John in the Eastern Cape on SMS. He says, why kill what works? Private healthcare rather than... okay, let me say it again. Why kill what works, i.e. private healthcare, rather than fix public healthcare? Does that not make sense?
Why are we killing it, son?
Well, he's suggesting that, of course, if you restricting people in terms of how much they can charge, it's killing what works. No,
it doesn't. Xolani, which other commodity is not controlled? Can anybody just wake up and say, I discovered that in this village I'm the only baker, I'm selling bread for 200 rand. If you tell them that, please sell it for a price that is affordable and acceptable, are you killing that bakery? Because it's the only one in that village, and you say, no, let's allow them to sell bread for 200 rand because they are the only ones. So we are not killing them. We are just saying let the prices be fair for the public to use them. We actually want it to work. We want it to be sustainable. Because, Xolani, at the present moment, believe you me, it is also not sustainable, even for them. And that's what is going to kill them, not us.
But you see, there's another element of these specialists that need to be paid for specializing. And we spoke to the dentist the other day, we spoke to Sama as well. And people are saying, well, we specialize, we go out, we study and so on. Society has got to pay us back for this, Minister.
Are we the only country where we have got specialists, people who have specialized, Polani? We're not. And is it starting today? The world has been having specialists for ages. I don't understand that. And that cannot be true, that they are being paid for specializing. But there's another problem, Kolani. Unfortunately, I've been trying to find out who caused it. I can't find the culprit yet. That in this country, you can wait and go to a specialist as the first point of call. In many countries, it can't happen. You can't go to England, for instance, and just wait into any teacher hospital or any specialist. You have got to be referred. So the problem is in the past, people used to go to GPs and get referred. But the law was made, I think presumably maybe by the Health Professions Council, and I need to look into that, where you can just wake up and go to a specialist, and that's very expensive. Let me example. If you are a housewife at home is, using a knife to cut vegetables, she got a cut. In this country, she can actually end up with a plastic surgeon as a first point of call, and that has to be extremely expensive. And healthcare systems don't really work like that.
Right. We will take our updates now. When we come back, we'll look at other countries. How do they work? I mean, some developing countries, of course, also who are facing, let's say, more or less similar disease burdens. How do they deal with these issues elsewhere?
The Forum at 8 with Xolani Gwala.
All right, I'm taking calls now on 0891 104 208. 0891 104 208. Let me read some emails first. Muzimbate Matadin says, it is indeed the survival of the fittest out there when it comes to health matters. And thank goodness I feel healthy today, because being unemployed and with no medical aid, I dread the day I'll get sick. I can only hope that the pain and suffering would not be as much as I anticipate it will be. That's Muzimbate Matadin on email. Another email came through from Mbulelo. We do not need a new name. Our current system is universal, but it is not functional. I do not want to pay plus or minus 3,000 rand a month for medical aid. I'm forced to. Many people will be prepared to pay the same amount to the public health system if it can provide me with the same service that I get from the private sector. Mbulelo on email. Another email came through from Vusi Sitole, who says, ask the minister, why are medical aid companies making so much profits? Why are we not taking the German example, where there are 3 medical aid companies who make no profit? That's Vusi on email. Another email from Kathleen in Drummond. It says, in previous decades, Best Med was indeed one of the best medical aids, proclaiming that it was not a profit-making organization. How things have deteriorated. And NHI is not the antidote, not with nursing ethics as they stand nowadays. Income restraints dictate that you have to choose in the lower range of benefit options. Bonita SponSave is the equivalent of a hospital plan with savings, but you try to have the kind of basic healthcare preventive procedure such as a mammogram, you will find that this option will not pay. The cost in private practice in KZN is 970 Rand, unaffordable. Medical aids these days have provided the private health sector with a cash cow. The non-profit ethic has gone out of the window to give way to glossy magazines, sports sponsorship and gym membership. That's Kathleen in Drummond. I'm going to get my guest to respond, but let me take some calls. Starting in Durban, is it Win? Good morning, Win.
Morning to you.
Hi, welcome.
I've got a lot of comments to make, but I'm only going to make 2.
Please.
The first is that every time Aaron Motsoaledi is involved in a speech or something, he always seems to be attacking the private healthcare system. Quite frankly, it's probably the only part of healthcare that's working at the moment. I would like to see him spend a little bit more time and effort on trying to fix the public healthcare system. And quite frankly, I have yet to hear any solution. We have such a huge shortage of medical staff, nurses, doctors, and everybody else. Yeah. And yet we have the same number of places at medical schools that we had maybe 30 years ago. There's been no attempt to increase the number of students at medical schools. That's number 1. Yeah. Number 2, the Department of Health always looks at the direct cost of healthcare. Now, if I've got to go and sit in a queue at a state hospital for 3/4 of a day in order to be attended to, we need to factor in that cost to me. In other words, if I'm not able to go and work, if I'm away from work for a whole day or whatever, you need to factor that cost. And when you add that cost in, it's actually much cheaper to go to private healthcare practitioners. Number 3, hospitals. The private hospital sector has to finance their own maintenance and their own refurbishment and upgrading of hospitals.
Right.
State hospitals, this doesn't happen. Addington Hospital now needs a massive refurbishment, and that's probably going to come out of the budget rather than Addington itself having to have made a profit and set money aside for refurbishment.
Win, let me thank you very much for raising those 3 points. I'm going to get my guest to respond. Let's quickly hear from Mike in Cape Town. Hello, Mike.
Hi, good morning, Stolani, and good morning to the panel. Just 2 quick questions following up from the previous caller. It just concerns me greatly that the minister is concerned about private healthcare. You just have to open a paper any day of the week, Minister, and you will find out that there's R1 billion irregular contracts issued to senior health officials with fraud. Professor Davies at the Charles Manensi Hospital is saying that every day he prays God and he sends children away to their deaths every day because there's not enough wards and beds to treat these children. And in fact, Minister, 75,000 children died under the age of 5. And of that 75,000, Minister, 23 died in the first 4 weeks of life. I'm saying to you, Minister, you are playing the biggest contract that we get to here in this country. You're taking... We have a crisis. You've admitted it that your department is in complete corruption, and yet you're going on about private healthcare. Minister, you're not going to forfeit. These private healthcare loans, you have people that are dying out there. One day you're going to have a class action for murder on your hands. You should be in a hospital right now saving lives. Not on a talk show, Minister. We have a desperate situation here. Leave private healthcare loan and get on with the job.
Okay, Mike. Unfortunately, though, the line is also a little difficult to hear now. But let me ask the minister to respond to these 2 calls, Minister.
Yes, Xolani, none of the 2 speakers has ever given a reason why healthcare costs have to escalate to the level where they are. I'm not the only one who said this, and I think the first speaker from Durban must go and read my speech. He says I'm always attacking private health. I'm saying nothing about public health. And in the instance, he even mentioned very wrong things. For instance, he has said we have done nothing to try and increase the number of medical students. That is a lie. We have done a lot. Last year only, we asked the universities to increase the number of medical students and we'll give them more money. That increased by 40 students extra. And we gave them 8 million rand. This year, all the 8 medical schools did so by increasing the number of students by 160, and we gave them 48 million rand for that. And we are also increasing the number of students who are going to be trained in Cuba from 80 per annum to 1,000, and we are sending them this year. Lastly, we have announced the building of the 8th medical school and the refurbishment of all the others so that the output of medical students move from 1,200 to 3,600. So he must get his facts clear. And I have said a lot about the problem in public health. All they are doing is they are accusing me for attacking private health, but they in turn are attacking public health. And I'm sure you have heard that. That is not the solution of what we are dealing with here.
All right, let me bring in Mark Haywood. Your thoughts on this? There is a temptation to make these comparisons and say, no, Minister of Health, focus on the public health care. Don't worry about the private. What are your thoughts on that?
Well, I don't think the comparisons should be made. The Minister of Health has responsibility for the whole health system in South Africa. That's the public and the private healthcare system. As he said, steps are being taken to try to address the crisis in the public healthcare system. Xolani, I would say to the Minister that we need much more dramatic steps because, as listeners have said, in many parts of the country, public health is in terminal crisis. There is widespread corruption in parts of the country that the Minister knows about, that he is powerless to deal with, but he's aware of it. There's a demoralization amongst many public healthcare workers. So we have to address that. We have to build this public healthcare system effectively and efficiently. So, but when the Minister talks about the problems in the private healthcare system, I don't think it should be seen as a witch hunt. I don't think it should be seen as attempting to kill what works. It's attempting to improve and make sure that the person who needs healthcare gets quality healthcare that is fair and that is affordable. Now, we know everybody knows. Anecdotally, there's many problems in the private healthcare sector. I can tell you my own experience. 2 or 3 years ago, I had a biking accident. I nearly broke my neck. I was in intensive care for 3 days. It cost 60,000 rand for those 3 days. And when I looked at the breakdown of the bill, I saw that one of the specialists who treated me, who'd literally come in and tested my reflexes, would charge 800 rand for just knocking on my knee. Because I'm not joking.
Are you all right, Mr. Mark?
Exactly.
And that's it.
Exactly. And that is repeated across many parts of the private healthcare sector.
Can I come in, Nicolan, as well?
Yes. Yes. There was also
Yes, from our side as well, in the private healthcare funding industry, we are saying the minister must intervene in the private healthcare sector. And we are encouraged by the way the minister is intervening. Because if the minister does not intervene, there is no other party that has got statutory power and even the authority under Section 27 to correct the ills of the private healthcare sector, which means the 8.2 million lives which utilize the private healthcare sector are left alone.
But you see,
they're left alone in the jungle situation.
Yeah, there were a couple of questions for you specifically, Dr. Zokufa, about how expensive our medical aid companies are. Somebody was suggesting, for instance, that why don't we go the German route and have a few number of these medical aid companies. In fact, they were talking about 3 medical aid companies.
Yes, there's a lot that has to happen in the medical aid country. I take the point. And I think if one would engage a council of medical schemes, they would indicate to you the various measures that they're embarking on to try and change the system. When it comes to the German system, when it comes to the French system, that is why we're supporting the NHI model. We, as a funding industry at BHF, representing more than 10% mega scheme, we support the intervention of introducing NHI because we feel that the introduction of that NHI, if it is done correctly, managed well, will begin to address some of the problems that are there within the medical scheme industry itself.
But Dr. Zokufa, explain this to me, because it appears as if you are suggesting you are, as medical aid schemes, forced to charge more by certain circumstances. Why? Because you have somebody, for instance, that's saying, I can't be paying about 3,000 rand a month for my medical aid.
Yes, if you look at the data for the last 5 to 10 years, you'll see that the contributions paid by ordinary members, the increases every year are higher than CPI. And then if you look on the side of paying the claims, the medical aid schemes have to pay those claims, and when they do, and they balance whatever they collected for that year and what they paid out, they had deficits. For the last 5 to 10 years, there have been deficits. So there's a situation here where the medical aid schemes takes money from the member, pools it, and pays claims, and hit deficits. And then you have these increases every year. For instance, it's difficult for me to say with great confidence that the current medical aid system we have, operating in an environment where the supply side of it is not regulated, is sustainable going forward. It is not sustainable going forward. That's why the minister has to intervene.
Minister?
For instance, yeah, hello, Kolani, can I come in?
Yes, please, because I would also want to know whether you think that you should intervene in the cost of the medical aid schemes themselves.
Yes, I'm intervening in everything, Kolani, and I've said, if you look at my speech, answering even the gentleman from Durban and Cape Town, I'm not the Minister of Public Health, I'm a Minister of Health, meaning both private and public, and I have to do something about it. I can't turn a blind eye at the private health care and say everything is going well. Yes, something is going well about quality, but definitely it's not going well about the pricing. And I think that's where the debate is. And they must stop this comparison, because in the speech, I said this whole concept, it's not about the beauty contest between private health and public health. It's about what is correct and what works. And let me give you a few examples, Kolani. Mark has just given you how he was charged 60,000 rand for what he has described. How I've got letters here from somebody who was charged 30,000 rand to have a perianal abscess drained in a child. You know, it's very, very small perianal abscess, and it costs 30,000 rand. There's a patient who was charged 500,000 rand, 500,000 rand for a peritoneal laparotomy because they had an abscess in the abdomen. Just to open the abscess, the abdomen, remove that abscess, cost R500,000. And I'm saying, and then I said there is somebody who was charged 15,000 rand for a circumcision. And I'm saying there is no scientific or economic reasons for this type of thing to happen. Okay. Nobody has ever responded to that. Every time you raise these things, this example of this gentleman from Cape Town and Durban comes in. No minister is talking ill of private health. No minister is unfair. No public health is collapsing. But they are not answering to this. How does an abscess cost 30,000 rand? How does a peritoneal laparotomy cost R500,000 rand? Who on earth can ever afford that? Which medical scheme can afford that? How does a circumcision cost 15,000 rand? So the results of all this, Xolani, is that the medical schemes raise their premiums every year. And Dr. Zogufa is right. If you check for the past decade, the medical scheme premiums have been rising at more than CPEX, more than Consumer Price Index. But every worker, if you ask every worker, they will tell you that they are not subsidized enough by the employer on the medical aid schemes. Okay. The reason being that, yes, the employers, both public and private, and I said so in the speech, public and private employers have paid enough for medical aid, but it will never be enough because as soon as the money goes in, it goes out in the form of these unreasonable claims that I've just mentioned.
All right, let me take Myaga.
Rand, 15,000, 30,000, and the 60,000 rand just for TP Herwood's niece,
Let's go to Myaga in Port Elizabeth. Hello, Myaga.
Hi, Xolani. Let me be quick. Two issues.
Please. Yeah.
I welcome the involvement of the minister. He's correct. He's not the minister for public health. He's the minister of health. I am in the medical aid, so to speak, in the private health care. I'm paying almost 6,000 rand, or my wife is paying almost 6,000 rand a month. That can South Africans afford that? When are we going to have insurance within the medical aid, a private medical aid system, where somebody pays medical aid for 20 years, and when he has to be attended within 7 months or 8 months, he's kicked out of the private hospital because funds have been depleted? When are we going to see the insurance so that if you are in the private medical aid, you continue to be attended even if the funds have run out because you've been paying for so many years? That's one. Two, Xolani, I want to hear the minister or Mike Hayward or anybody who's there talk to us about the pressure that is put by private healthcare into public healthcare, because some of the budget has been taken away by this huge pressure that is being put by private healthcare into public healthcare. Facilities that can be affordable to public, they are no longer affordable because people are pricing as in private hospital.
Okay.
You will talk about the maintenance, you will talk about the utensils, you will talk about the medication, you will talk about these specialists that are now not willing to go to public because public cannot afford to pay them.
Okay, Myaga, thank you very much in PE. Let me quickly go to Bukhosi in Sandton. Bukhosi, good morning.
Petro.
Baba.
Yeah, Dr. Motsoaledi is right, but there are two problems in both sections, public and private.
Yeah.
In private health, the figures that he quoted of exorbitant figures for medical procedures are not a surprise to me. I had my specialist physician go on pension. I had to find another physician. The physician that I was sent to was in Mill Park. He told me that he's not accepting medical aids, and he wants an upfront consultation fee, Xolani, of 3,000 rand. Just consultation without doing anything else. I had to scout around. I found another highly qualified senior specialist, physician specialist, and he charges me 350 rand for a consultation. If that is not extortion, Xolani, tell me what it is. And the people who are saying Dr. Motsoaledi is hammering the private sector, they really need to reconsider this and know what we are experiencing. Secondly, I want to know, Motsoaledi, what are you doing with NHI looming? What are you doing to restoring proper nursing training in a provincial hospital? Basic training for nurses with bedside training, 3.5 years training. And then after that, post-basic training, PHC, which is your pet speciality, 1 year extra from basic training, midwifery, ICU, like it used to happen pre-1994.
Okay.
How far are you with that project? Because that's where the problem is in our
public hospitals.
Public
health. Okay, sure. Bohosi, I thank you very much. Let's quickly hear from Sipho in Limpopo. Hello, Sipho.
Morning.
Hi.
I want to start by encouraging the minister. Minister is the Minister of Health, both in private and public. The people who talk like that are people from Republic who are always ready to criticize the government when they are doing great. Private health sector, we agree. Those people in private sector, they are not controlled. They need to be controlled. And the minister is from ANC. ANC, they are majority in the parliament. They must just go to parliament and actually stop wasting time. This private sector system is not, it's not sustainable like the minister is saying. They must just pass the law as quickly as possible so that people who actually think that they can afford the healthcare but who do not want to go to public health sector is not coping with the demand. With the demand in the country. Must actually afford the health sector then, because it's very expensive at the current moment. And just to encourage the minister again, I'm thinking on the issue of increasing medical officers in the public health sector system. If you go into rural areas, there are many people who actually pass matric who do not have funds to go to universities to be doctors and nurses and other healthcare professionals. If they can actually concentrate, especially in the rural areas, it's very unlikely that someone who's from deep rural in Limpopo or somewhere else in the country, after passing matric, their first port of call will want to go to Canada. These people will want to stay in and will actually prefer to work in those rural areas where they are coming from. But if we concentrate on just making these university fees expensive, making it difficult for people in rural areas to actually go to school, who actually even qualified to go and become doctors and nurses.
Okay,
we're still going to experience the same problems of healthcare professional shortages in the public sector.
Okay, that's super. Thank you very much. Last caller, Sebastian in Cape Town. Hello.
Yes, morning to
Hi,
you.
Welcome.
The problem is this: the contract worker employed by a broker at the Cape Town International Centre, which I saw in the paper, is paid 18 Rand an hour. When he's sick, he has to go to a specialist. It's going to charge him more than 1,000 Rand an hour. How can that? And that applies across the country with the mass of the population out of proportion in terms of what they paid versus the specialists.
Yeah.
You go to a mediocre private hospital and you charged at more than a 5-star hotel would charge you for much better accommodation on that side of their operation. Basically, it's blatant greed and profiteering across the board in these two sectors, specialization and the private hospitals, and the minister is totally correct on that. And we need an intervention. We're supposed to have a competition authority, and that needs to step in and just basically cut down on these prices. But if you look at what the specialists are looking at, they're not comparing their earnings with the average population who they're charging. They're looking at their colleagues across the waters and saying, oh, poor little us, we are paid peanuts in comparison to them, and we need to continually jack our prices up so that we can be paid in international terms. And that's actually what all the high government officials have actually done as well. And that also becomes a function of the exchange rate. So while we live with a depreciated exchange rate and this sort of philosophy, we need to be paid at overseas rates, we'll have this problem continuing, and that's going to also scupper the national health, because a lot of other components of the whole medical scheme are priced in overseas terms. Either they imported from overseas or they're going to be priced up to importation comparison pricing. So unless there's a change in exchange rate policy and actually strengthen the rand, we'll continually have an unaffordable for the mass of the population health sector.
So, thank you very much, Sebastian. I think he's touched on a very important point that we haven't spoken about. Minister, perhaps you can touch on it. The issue of the equipment that's imported here, because private hospitals will say, well, look at this, we're importing this equipment.
Kolani, there's a report given by Botha Steenkamp, a researcher for the Council of Medical Schemes, to Parliament. The same report appears on Judge Judy Qualapen's report when he was the chairperson of the Human Rights Commission, that this equipment in South Africa is more than in many rich. In fact, the report says we have got more equipment than the whole of England, despite the fact that it's a highly developed country. And Mr. Botha Steenkamp calls it medical arms race. That means this equipment is bought in order to do lots and lots of investigations that are not necessary in order to charge people. Judge Judy Kwalapel said their research in the Human Rights Commission found that an average middle-class South African, when they are sick, they are more overserviced than their counterparts in England. And I wanted to understand what does that mean. They said, no, there are lots of equipment which you must go. You go through an X-ray, magnetic resonance imaging, CT scan. In other words, it's just investigations and investigations in order to charge for more money. Now, lastly, Xolani, Bohoshi has got it, very, very clear. And I've got another example. He is saying a specialist wants to charge him 3,000 rand. Another one for the same job, for the same thing, is 350. Do you see why I call it the law of the jungle? I had a doctor colleague who wanted a dental procedure on his child, and they quoted him 21,000 rand. Because he's a doctor, he phoned this private hospital and said, no, but this is madness. They told him to go to hell, that this is their price, there's nothing he can do. He phoned another private hospital, and they quoted 5,000 rand for the same procedure. Do you see the difference is where I'm saying it's a law of the jungle?
Okay, Minister, I'm out of time. But I'm looking at these measures that then you announced. One, there will be a competition commission inquiry. Is that correct understanding?
Yes, the competition commission must do a market inquiry to reach to the bottom of this. But Dr. Zogufa said the ruling they made a decade ago is also problematic, and I'm discussing with them about that ruling, because they ruled in the healthcare sector as if it's any other commodity. And I want them to look into that and look into the issue of the market inquiry.
And what about asking the president to sign that amendment then pretty quickly so that...
For them, yes, to do that market inquiry, yes, I was made to understand by lawyers that that's what is wanted. And I've been approaching the president's office about this issue, that in order for the Competition Commission to have the legal power to subpoena, they need to sign that act. And I'm going to try my best that it should happen.
Mark Haywood, very quickly, your closing remarks?
Yeah, just very briefly. I mean, the minister has a constitutional duty. That's what he's doing, to ensure everyone has access to healthcare services. The second point is that the conduct of the private sector impacts on the public sector. You can't separate them out completely, and public impacts back on private. And the last thing I would say is this is necessary for all people in South Africa. So I would urge the private sector, people who use the private sector, let's not turn this into a dogfight. Let's make sure that we can advance the interests of all people in terms of access to healthcare services and get out of the mess we're in at the moment.
Sure. Dr. Zogufa, very briefly.
Yes, fully support the initiatives of the minister here, very much encouraged. And I would urge that all parties do so. I'm encouraged that Mark Haywood, Sector 27, is supporting this. I would encourage labor movements to encourage this. You'll only feel it when it hits you, that really this is a jungle.
It is indeed. All right, I thank you all for coming through and talking to us this day, starting with Minister of Health, Dr. Aaron Motsoaledi, Dr. Humphrey Zogufa, MD of the Board of Healthcare Funders, as well as Mr. Mark Haywood here with me in studio. He's Executive Director of Section 27. Thank you for listening to our program this day. Thank you for the SMSs and emails as well as calls. Thank you to the team, our producers Misho Shantlale and Wisani Makubele, senior producers Lungile Mabaso and Chiliji Chibase, for technical producer Judy Mutupi, Forum at 8 producers Nomalizo Mandela and Jake Mukoma, chief producer Budzi Lukoto, executive producers Busi Chane and Aubrey Sechia. I'm back again tomorrow between 6 and 9 here on SAFM. For now, though, it is 9 o'clock, and that means time for Morning Talk. Cheers from Oliver. 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 Morning Talk.